Welcome back to Favaloro Foundation University Hospital. We are here at the lab number 1. She's a 76 years old lady. She's presenting with dyspnea and also an episode of pulmonary edema on May of this year. So she has a normal ACG on a normal sinus rhythm with normal PQ. According to our team, is not futile for a TAVI procedure or aortic valve replacement. So this is the coronary angiography. You see a long stent on the right coronary artery with the tight stenosis in the distal and edge and moderate to severe on the proximal edge. There is calcification on this area. Next, we also observe the calcification of the aorta. This is the left coronary arteries. The left main is very short. This is the CT scan showing a 13 by 25 millimeters diameter on the annulus with a perimeter derived of 22. The LVOT is a little bit bigger. This is the annulus and also the sinus of Valsalva of 33 with significant calcifications. A view of the tricuspid valve with the significant or heavily calcification of the 3 leaflets. So in this case, we are going to predilate. This is the angulation, and here is another measure, significant ventricular hypertrophy and not a significant calcification on the ascending. So these are vascular access. The right femoral access is a huge artery without significant calcification. PCI to the right, to the left, the circumflex and the diagonal, and then to proceed with the TAVI implantation. So we use a regular wire by a radial approach, probably right or wrong, I don't know. We decided to use a nominal balloon with the stent. The stent implanted was 3.0. We used a 3.0 long balloon for predilatation of the whole segment. But after this predilatation, we have this significant perforation. So we decided to, at this moment, immersion the enclosure of the vessel, inflating the balloon that we use for predilatation. So we have a perforation of the adventitia. So we have a pericardial effusion. So here is what we did. So meanwhile, we have a 3.0 balloon inflated. We deflated for a second. We crossed with the second wire through the second guiding introduced from the femoral. As you can observe there, the long inflation was not sufficient to fix or to seal this perforation. The patient was still stable, and we decided to use a 3.5 by 22 covered stent, leaving the wire behind the stent of the first guidance just in case. And as you can observe there, there was a complete sealing of the perforation. It was not necessary to recover. So we did a pericardial puncture, and we introduced a 6 French sheath with a 6 French pigtail. And we aspirate 250 cc's from the pericardium. So today we are prepared for TAVI. We thought to prepare this patient for percutaneous femoral access. And due to this angulation of the aorta, we thought about of using a balloon expandable with a deflectable catheter for this TAVI procedure. She has an area of the annulus of 354 or something like this. So we decided to use 23 minus half of the centimeter. So it's going to be about 8, 9, or 10% oversizing of this annulus in a big calcified artery.
This patient have a severe aortic stenosis with a peak gradient of 68 and mean gradient of 45. This patient have a normal ejection fraction, a little mitral annular calcification with mild mitral rotation.
We use an hydrophilic wire to go to the superficial, and then we leave there a long 018 wires. You know that probably we are too old, but we still leave these wires contralateral. Have an 11 French sheath on the right femoral in the vascular access, because we were waiting for life for 30 minutes. It's not ideal to have a huge sheath in. So we have an extra stiff wire, and we are going to introduce the sheath from Edwards here. To introduce this sheath, it's important to hold it because there is not a lock. Date vuelta, Joaquín. Because if not, it disconnect one from the other, and you can damage the artery. And then I'm gonna fix it because it's a hydrophilic catheter which is gonna move during all the procedure. I have a thread here to fix the sheath to the skin. Let's see. This is a very tight stenosis. Probably we need the amplats a little bit bigger. You see how tight is the stenosis? Let me test there. I don't know. Sapien 3, it is supposed to be better for coronary protection because we don't have a too high crown. We have a big cells in the proximal part of the valve. You see how difficult it is to cross? So probably we should use the amplats wire here. Show me the catheter. Now we are in a better position. Give me the amplats. Okay. To be honest, I don't remember the case with such a difficult for crossing. So we are repositioning the catheter distally with the amplats. We are okay there. Now I feel better. I think the position is better. I think we probably cross between the commissures, but near to the septum. So we are going to check the gradient. So we are going to predilate. Carlos is gonna pull the catheter, leaving the wire in this position, Carlos. I don't like it. Let's go a little bit more Mahape. I think there we have a better overlapping of the right and left cusp. So we are going to use the Edwards balloon for predilatation. People is gonna pace in at 180. We are connecting to the wire. Pacing. Prepárate para desfibrilar porque me parece que. Okay, deflate. Take it out. It's okay. So we have prepared the 23 with half of cc less, which is going to be about 10% overlapping. So be careful. Valve is come from Edwards. Okay, here in this position, I can see the valve and also the wire. The valve is gonna be out of the sheath now. So it's okay. Now Carlos is gonna push the wire. I'm gonna retrieve the balloon until the white marker. You show my hands. I have the white marker here. And I locking again the device. I'm gonna introduce the balloon inside the valve. So I will check it in a better projection. Probably the valve is a little bit into the sheath. Here, okay. So here we see that the position of the balloon is okay. We see here much better. So I'm gonna torque deflect the catheter. How it's navigating this very tortuous aortic anatomy. I'm gonna torque deflect the catheter a little bit more. You see, I'm gonna cross the valve very slowly, very smoothly. I think the position is okay. Anyway, I have to unlock and to retrieve the deflectable sheath until the two markers. Trying not to move the valve, which is almost impossible. I have to pull a little bit more to allow the balloon a complete and free inflation. I'm gonna test. Okay, I think it's okay there. So connect the pacing, 180. And we wait for a good pacing. If not, we will have to change. Okay, let's go, Carlos. Let's go, let's go. Full inflation, full. And pushing a little bit, deflate. Okay. Now give me the amplats wire, stop the pacing. We decrease pacing very slowly. She has some bradycardia before. I can do a minimal test before pulling everything out. Let me pull the catheter out very slowly, as I always perform. And let me do an answer here. We have some paravalvular leak, but in my opinion, one extra CC is going to be okay. The oversizing is going to be 12 or something like this. Is not too much, and she has so severe calcification.
Oscar, we have a wire inside the valve.
Yes, yes. The wire is still crossing the valve, so you might have some central leak.
Yes.
Important to see we have paravalvular leak.
Yes.
I saw something near the
We
septum.
only see a mild to moderate central aortic regurgitation, but
Not paravalvular.
I don't see yet
Okay.
the paravalvular leak.
Okay, let me check again. That's on the right view. Okay. Still have parallax there. No, I think it's central. You are right.
Okay.
So we don't have.
If you want to check again.
I will undeflect. And Carlos is gonna pull. I hold the sheath, and then I will introduce the pigtail. And then if everything is okay, we are going to close the balloons. Okay. So the question is, which is the advantage of self-expandable instead of over balloon expandable valves? So I could say that self-expandable is a better option when you have calcification or significant calcification on the LVOT. The next patient, in a way, is one example of this. This is a patient with a notch of calcium on the LVOT. So probably there is not a good idea of the balloon expandable valve. On the other side, heavily angulated aortas like this, I think balloon expandable with deflectable catheters are much better. Actually, on the instruction for use of the Evolut, 60 is over this. So it shouldn't be a good patient for self-expandable valve. A patient like this one with 60 degrees of angulation. Give me the amplas because extended are twisted. Give me a second. I don't know if we have any other situation where we rather like one or to the other. The other would be for valve-in-valve cases with the small valves. They are probably self-expandable valves will leave a little bit residual gradient. If you have a low coronary ostium, probably balloon expandable would be okay because you can protect it a little bit better. You see on the left of the monitor, we don't have any gradient. And diastolic is okay with a very nice notch that there or indentation. And here is a good position for the anangio. I think the outcome is okay. I shouldn't go too high with the oversizing. Remember that we were about 10 with half of CC less with the 23. And also we have a huge calcification. You can observe the calcium behind the stain frame. And I don't like to destroy the annulus before taking a plane for TVT. I think this is a very nice outcome. So I would ask Dr. Salmo to check again without anything crossing the valve. Give me a second. Regarding conduction system, we have almost the same than before. So the ACG, could you show the hemodynamics? Probably there you can see the ACG. We have probably a little bit of left bundle hemiblock, but nothing else. So Joaquin, so 6 French, give me some light here. Any other question, Andres? So we have used only one ProGlide because we did echo-guided puncture. It's almost a normal
Yes.
femoral artery, huge. It is supposed to be sealed quite easily. No, here is okay, because if not, we are destroying the image. Moving the table. Come here, Joaquin. Give me first the balloon. Yes. Yeah, I will cross with the balloon just in case. Which is the reason why we're still using this? Well, because for sure, if you have a huge problem, it can be easily solved by contralateral size. From radial approach, sometimes you don't have the stents, or you don't have such a long balloon to cover. Surgery could be an option. Show me. But in a way, what I mean is we are still talking about closure, because no, móvelo, Calao, sácalo. Because closing or closure access is still an issue for TAVI. Not as frequent, can venir acá, but it's still an issue. ¿Revertiste un poco, Jaime? No, tenémelo. I'm gonna pull the E-sheath, and then I'm going to introduce the 6 French sheath. Then I'm gonna tie the ProGlide. I will check how things are going on, and then I will decide where to use the 8 French angiosyll. Aflojame. So as you can observe here, closing is almost okay. We don't have bleeding. But as we cannot revert the completely the heparinization, I would rather like to use the angiosyll here to be sure we are not going to have any problem. Remember, this is a patient who had a bleeding complication. I don't like anyone more. So I'm gonna put the 8 French sheet, and then the angiosyll, and then we will close the contralateral side, and we are done. Why I leave the 6 French sheath is to be sure I can cross the suture with the 8 French introducers sheath of the angiosyll, and not destroying the previous suture. Okay, I have backflow here, and here I'm sure I am in. Now I pull everything out. So for sure, everything is closed. We are closing here. We are going to test to be sure everything is okay. Give me use. Okay. So this is digital subtraction. Everything is perfect. So now we are going to pull this. Remember, once again, first you have to pull the wire, not to damage the carrefour, and then you close here. Remember, the take-home message of this patient is how to solve a perforation that can occur whenever. Always unexpected, sometimes expected. But in this patient with the regular balloon, nominal with the stent, and using nominal pressure, we have a perforation. This patient is going to be in a regular follow-up, echo follow-up at 1 month, echo follow-up at 6, and then we will check everything. So we will leave the venous access just in case for a few hours, and then we are done.